So let's see. So next we have Craig Bim from CRISP, who's going to talk to us about TEFCA and what's going on in the CRISP world. So thank you for joining us, Craig.
For having me. Oh, you don't have to clap. I haven't done anything yet. You don't need to clap. And it's a post-lunch crowd. I will keep us on track. Luckily, most of this was all about what TEFCA is. No, I wouldn't do that. So thank you, Jay. Thanks for having us. We're really excited to be participants with eHealth Exchange. We're really excited to kind of follow in through their QHIN footsteps. And really what I'm here to do is share our perspective as an HIE and an affiliation of HIEs with regard to TEFCA. So first, just if you're not familiar with CRISP, we started in Maryland as Maryland's Health Information Exchange. We then partnered with a number of HIEs in our region and then also Alaska, of all places, where we really want to share the infrastructure that we have been dedicated in tuning to create kind of efficiencies across the local governance and use cases. So we'll talk about how that fits into the broader world. So first, I thought it might be helpful, we get really into the weeds around what are the policy implications or what are the different implementation guides or what are the timelines. And that's all great. We have to do that work. But I think taking a little step back, when I think about why TEFCA, it goes back to what are the principles, what's the point of TEFCA? And I won't say all these because Mickey and others have summed it up very well. But I think it's important to remember that as an industry, we're very much aligned with the goals of TEFCA. It also is not perfect. And as a pragmatist and just kind of our approach to things, I think it's going to be much easier to influence TEFCA and implementation and policy as a participant rather than from the outside throwing stones. And so we agree with the general direction. We agree with the approach. We agree having a floor is appropriate. But we don't need to settle for that. We can participate and make it better. And that's really how we do many of the things we do. That said, while there are plenty of benefits, which again is what you've been hearing about a lot for the past few days, we do have some serious risks. And that's, again, what we're working with our local stakeholders and partners, but also Jay and his group to figure out. And so, for example, as much as we want a really effective, standardized, secure, nationwide connection, we don't want to disrupt all the hard work that happens locally. We're really proud to say that our use cases are deeper and richer than most of the things happening on a national scale, which is the way this works, right? You can innovate locally with partners at the point of care, and then we have to scale them somehow. But I'd be really, really worried if we started to see kind of federal mandates and guidelines come out that disrupt all the good local and nuanced work that many of us are doing. Similarly, there are providers that work across regions, across states, across networks, and we need those providers to get all the data they are entitled to get. That said, we also need to preserve patient choice and opt-in or opt-out, and I think some of those consent nuances are going to be lost in these conversations. So there will be an effect on HIEs, but I think we can mitigate the downside, and there's plenty of upside. So the next kind of natural question, so if we're bought into TEFCA, why will we buy into TEFCA through eHealth Exchange? And quite frankly, this slide maybe speaks for itself. I might steal it and just say, like, this is what CRISP is, because the eHealth Exchange values are very, very much aligned with a nonprofit health information exchange. And so we love the idea of a public good. We're really excited by its roots, its deep roots with the VA and in the federal government, and just in their demonstration of the value that they're bringing across all stakeholders. And we've carved out, I think, some really helpful lanes for ourselves in the sense that they are doing work that we don't want to do in terms of compliance and national connectivity and managing through all the complexity when it comes to the federal government. And I appreciated hearing that earlier. But I think we do a lot they don't want to do, which is working with boots on the ground behavioral health groups and the community-based organizations and some of these providers that have EHRs that haven't been updated in 9 years. So it's a really good match. But all that said, I think it's fair to characterize our approach as point-to-point connectivity. The floor that TEFCA provides is too low. Like it's great, it should exist, we support it, but there are many bigger and better things that we should be doing together. And so we talk a lot about innovation and what that might mean to us. So for example, as CRISP shared services and our health information exchanges work within their networks to scale patient consent, because we can do things like opt-in for SUD data sharing, we can work on kind of individual state laws about behavioral health records and adolescent records and all the things that are not standardized across the federal government. We can pull that data into the network in appropriate and thoughtful ways. We can scale it through eHealth Exchange and TEFCA, and then hopefully the lessons learned about maybe where the policies differ or where some of the technology does not allow for this extra work can be scaled at the national level through our lessons learned. We also think that there are going to be some new types of records. I like to think a lot in terms of breadth and depth. Maybe to make this simpler, eHealth Exchange has the breadth. They have the national framework, but we have the depth. And so in the District of Columbia, for example, we're working through the Department of Healthcare Finance, their Medicaid agency, to get public school truancy records and link them with healthcare providers, because there's a very direct correlation between missing school and poor health or lack of kind of adequate health care. So it's an equity program, it's an access program, and it's funded by Medicaid. That is not something that we can do 50 times, kind of out of the box through this national framework. But perhaps, once we establish that as a use case, we can help scale the concept, the reason for the data exchange. We could share policies and principles and guidelines. We could even potentially share the fact that some of those students were at risk for certain access issues, which would be relevant for providers on the broader scale. So I think there's a lot of space for new types of participants and the depth that an HIE and a health data utility could bring back to the surface. Maybe I made up a lot of time. We're going to have a lot of time for discussion. But I think that last point about the space to work, I think maybe the biggest takeaway here is that we all have a lot of work to do. And there's more than enough to go around. And so while my teams are working on those Medicaid use cases and trying to get data about the unhoused through Baltimore City so we can connect people to services better, in parallel, Jay and his team can be working on the implementation guides and making sure that they are the first QHIN that's certified and moving data in production. And it's a really nice partnership when we can leverage each other for what we do best and not have to worry about the areas that we're not good at. Because I do not want to have to worry about the federal government and federal standards and the nuance of TEFCA policy. It is not worth my time because we have really talented partners that are better at it. And I think it's fair to say that that eHealth Exchange doesn't want to have to worry about the age of consent to sharing data differences from West Virginia to Maryland, because instead we can worry about that and push all the data up that's appropriate to be pushed up. So maybe across that broad theme, we can have discussion or questions, because I know not every HIE agrees with this approach or is maybe as open to it. And we tend to be very pragmatic and maybe a little bit too optimistic for the industry. So what questions do we have?
Yeah, hi there. Paul Matthews with Ochin. So I'm a national cross-state organization. I'm connected up to multiple HIEs, regional HIEs across the country. One of the things I was thinking about from this morning's discussion around signing or opting out of the QUIN if it's eHealth Exchange and being able to share my data still, because I can only connect to one QUIN. How will regional exchanges offer up to their members, in your opinion, the ability to opt out so that I'm not having to modify my participation agreements with every regional exchange. Has there been any conversation at your organization? Do you think other exchanges will have a similar approach to the eHealth exchange of opting out so that the exchange directory, so the directory itself isn't suddenly directing me and routing me in the wrong place?
Yeah, so there's a lot of complexity in that question, as I'm sure you know. So let's start by saying that we recently updated our HIE participation agreements to try and capture as many of the flowdowns that we thought would exist as possible. So we should be generally in alignment with more or less the paper. I also think it's very likely that most of our HIE participants will not want to participate through us to access kind of QHIN and meet TEFCA requirements. There are other groups out there, namely their EHR vendors, who are going to kind of provide that as a service, and that's wonderful. And so I think it's going to be a challenge, but it's going to fall to the HIE to determine how do we manage multiple types of roles within this directory, which is something we certainly can do, but it's going to be kind of a new level of kind of master data management at the provider level that we need to work through. And then I think the bigger question for all of us is how do you remove duplication from the system? Because it's going to be very natural for kind of all the data to get to different places through these different tunnels, which is probably a bigger question. The way we've been addressing that is essentially we try not to share CCDs from a provider that is also sharing CCDs with a national network. We try to only share data that is kind of unique to how we package data. So if it's a care team relationship that we know because of multiple points, we'll share that up. So that's a way we're trying to remove duplication. We're also thinking through, is an HIE's role perhaps to show a longitudinal record, but the point-to-point connection can show a specific encounter record. And so if you're a provider and you want to see what happened at Johns Hopkins, great, go check Johns Hopkins. But if you want to know that entire patient history, perhaps we can package it better and serve it better. So I quite frankly don't have a final answer, but I think there's a lot of space. The technology is pretty much there. I think our data model is pretty much there, and it's really just working through the business cases to figure out kind of what's actually useful for the end users. What other questions do we have?
So a question about consent, because you touched on it, and Chris manages it in 4 different states. We're looking at it in even broader. What do you see as a framework for starting to manage how we share that, given the state-by-state differences that are out there? What sort of thoughts have you guys put into that?
Yeah, no, that's a really good question. So we can serve up consent through kind of standard FHIR API requests. And so a framework that actually the Maryland Healthcare Commission has been trying to work through is if you're calling across networks, should you check with a consent repository first before returning data? I think as a conceptual model, that somewhat makes sense in the concept that if a patient's consent can be registered, captured, and honored in one place, it means they don't have to opt out of 19 different networks and kind of have data trickle through different places. I think there's some very serious concerns around, first, the responsiveness of a single kind of consent manager and the millions and millions of calls per day or per hour that they're going to receive. And then kind of the second half of that issue is, can that consent, kind of where within the workflow should that consent manager live? Because if you're an EHR, for example, if you're Epic, kind of which of the Epic transactions are across entities and therefore subject to opt-out, which ones are not? And how many critical paths do you want a different third party to live in? So kind of conceptually, I like the idea of a single consent utility. I think it has some appropriate concerns from kind of anybody who's not that consent utility. Beyond that, I'm very open to other people's ideas. I think it's really difficult to expect consumers to engage proactively in all the different ways their data is going to be exposed. But as an industry, we really have to figure it out because there's going to be a lot of data flowing in a lot of different places. also happy if people have better answers than I do, because clearly I don't have that many.
Hey, Craig. What about, I'm wondering why now? So, CMS has made participation in TEFCA, which doesn't exist yet in reality, an optional way to meet some check-the-box scores in promoting interoperability. But given that it's not required and it's just an option, what's your thought process on starting early?
Yeah, so we were actually talking about this at lunch. There are at least two good reasons. The first is that as an industry, and certainly the CRISP approach has been to focus on the future, not the past. And so I think it's really important that we look to fight the next battle and kind of get over the fact that TEFCA exists and is the law and is going to be deployed. As imperfect as many folks kind of believe it is what it is. And so by participating and moving on, we can shape the policy, shape the implementation, and again, be looking to where the puck's going to be, I think was the quote earlier. So that's the first piece. There's no sense in relitigating that. The second piece is that I do firmly believe TEFCA is the floor, and we want to do many bigger and better things beyond TEFCA. I'm sure all of you saw the proposed rule around prior authorization and payer-to-payer interactions. I would much rather be talking to this group about how can we have a better prior authorization process, because so many of us are connected to so many of these different repositories and workflows, rather than fighting about the fact that we now have these new kind of trickle-down clauses we have to update legal agreements about. So I think there's a lot more innovation. There's a lot more space for innovation, and that's very much where we would rather be focused.
Hey, Craig, maybe since you said lunch, I thought it was a prompt. So how do you see providers that are getting into a bit of network fatigue, for a lack of a better word? How do you see them working with state HIEs like you versus the national HIEs versus whatever is coming with TEFCA and all that?
Yeah, so first I would say I think there are probably as many options as there are networks and providers. So there's not a one-size-fits-all, nor should there be, quite frankly. The way our perspective on it, and I'm going to take a minute to divert into the concept of a health data utility, which has probably been talked about in various forums, shouldn't be new phrasing. But most of the HIE industry, I think the more capable, robust HIEs and probably HIE-adjacent organizations are thinking through to a utility model where you would have all the efficiency of kind of single sets of pipes. You would have the appropriate governance level that should exist locally. You could layer on a consent utility, and then those health data utilities can and should share all of the data with exactly the people that are allowed to have it, kind of no more, no less. And in that framework, as long as, and this is a big as long as, but as long as the health data utilities are funded in a sustainable and equitable way, all the data can flow in relatively standard means to relatively standard endpoints. So for example, in kind of the Maryland, DC, Virginia, West Virginia, the area we're in right now, if you participate with any of the HIEs, not yet Virginia, although Virginia in a similar version of this, if you participate in either CRISP DC, or West Virginia Health Information Network, and you pay participation fees if you're subject to them, you can have kind of all of the data for all of the permitted purposes that any of those HIEs allow for. You can also get that data through eHealth Exchange or other national networks. And if you have a business associate you'd rather the data go to, for no extra cost or discussion, we will push the data to that business associate because it's your data as the participant who signed the PA and pays the fees. And I think what that allows for, we need to figure out the normalization and how, even if you have to do that 50 times instead of 500 times, it's still probably 49 times too many. So we have to deal with the standardization. But I think what that does, it creates a marketplace kind of above the utility, where there can and should be really smart, thoughtful, innovative companies that are acting as business associates, that are doing research and are doing better analytics and creating better user interfaces. But they're not fighting over the data or access to the data. They're leveraging a really robust utility that is providing the data. So again, probably like most things this week, this is years away. But that's at least kind of our vision for how we fit within this marketplace of ideas. We should be the efficient one-stop shop for all the data you're allowed to have. And then we love the fact that there are really thoughtful companies that are doing more with that, with their clinical partners.
Hey, Craig. You heard of Sacagawea?
Yeah?
TEFCA? That's what you guys are? You're like leading the charge onto the... Anyway.
Just give me
I
a
got
gold
thumbs
dollar.
down. Okay. Question for you after the cheesy after-lunch joke. Do you, so Maryland's a little bit unique, right? Because there's a required participation, and some other states also have required participation in the HIE. I know you guys have probably thought that through, like how will that look as a provider that has to participate at the state level, but that has an EHR maybe that's already a QHIN, but like how's that all going to play out in your mind? Have you guys got a model for that yet? Thanks.
Yeah, so I think the first really important point about this is that anything that's shared at the state level through the HIE, whether required or not, should count towards any federal mandates or programs or policies. That's why we love the idea that HIE exchange is part of interoperability for QPP. It makes sense that you could share data once, and then if that group can share it multiple times, that you get credit for it. I don't know yet how state mandates would conflict with kind of QHIN concepts. I don't think there's going to be a lot of issue with it, unless someone like the CDC says, you must share data directly with me no matter what, or through this framework no matter what. I think there's plenty of room to work, because on a state level, even again where there are not mandates, there's going to be certain types of exchange, certain reportable conditions that matter to Maryland Department of Health that don't matter to the health department in DC. The data will be shared and exchanged and worked through. And so I think as long as kind of provenance and governance and the infrastructure can decide what goes up to QHIN world versus what goes down to health department world, we can avoid too much kind of overlap between conflicting mandates. But again, it does rely on thoughtful policy that says, let's leverage a health data utility rather than require direct feeds around the health data utility.